That's fine.
I've got a CV also. So I'll just,
Okay.
so the current case student and the teachers you can introduce. Then we'll start off with the case. Actually, today is Army Day also. So
is it?
later. He's gone for the parade, but he'll be back in time, he said.
Yeah. Yeah, I think Shashank is also out for some commitment. So,
yeah, sure.
Of course, I don't have CV of Girish, and but I think
no, they are like in-house, huh?
Yeah, we don't.
You don't need to introduce them formally. Yeah.
Sure.
Dr. Shankar is a guest speaker, no? So usually guest speaker.
Absolutely.
Yeah. Shweta is there. Dr. Shweta. Actually, she should just try her slides once. Yeah. Have you done checked your slide share and all?
Yes, fine.
I can just try it out. Yeah.
No, it's okay.
We can't see, huh? We can't see your slides.
Yeah, it's still. I think now we can.
Now we can see. Yeah. Okay. Right. That's fine. Yeah. You can hear us, no, Shweta?
Yes, ma'am.
Yeah. Okay. And you can speak a little louder when you're presenting. Maybe raise the volume.
Yes,
yeah. Okay. So we'll just wait for Dr. Yojana and Dr. Who's the second?
Girish is there.
Yeah. So once they
Dr.
join.
Vajanti, I think, is unable to.
Yeah. She's unable to come. So we can ask in between, we'll pitch in, let them to start, Dr. Yojana and Dr. Girish. That's why I got 3 chairpersons, so that if somebody last minute, like last time also Dr. Praveen couldn't make it.
Okay. And Shweta, you are which year resident in rheumatology? I didn't have the details, so I just wanted to introduce you that way.
I am fellowship, sir. We have just given the exams recently. I've completed 1 year, sir.
You have completed your first year, so you're just beginning your second year in rheumatology at DY Patil, Pune, right?
Yes, sir. I'm a fellowship, sir, resident.
You have a 2-year fellowship there or a 1 year?
Ma'am, no.
You actually completed your fellowship, no?
Yes, ma'am.
Just exams are just over, yeah. They have a 1-year fellowship at DY Patil, not 2 years.
Okay.
At Kokilaben also you have a fellowship program?
No, ma'am. We haven't. I mean, we have been looking to start it, but I think there are a lot of technical issues. Last 1 year, I desperately chased it, different kind of fellowships, but I realized administrative things are not so simple. Clinical things are easy.
Easier. I think Dr. Girish is joining now.
Yeah.
Dr. Girish is joining and Dr. Yojana is yet. Hi, Girish.
Hello, ma'am. Good morning, ma'am.
Good morning. You can hear us?
Yes, ma'am.
Yeah.
Am I audible?
Yeah, you're audible.
Yeah, very clear.
For Dr. Yojana.
Yes.
Then we can start. People will join in like Sunday, no? So plus today is Shankar Subramaniam also. So.
Girish, you're at Jupiter, right? Pune?
Yes, sir. Yes, sir.
I don't know why I always had in mind that you were at Nagpur somewhere. Were you there previously or never there?
Never there. So Parikshit sir is there. Dr. Parikshit Sakdev.
Okay.
Dr. Girish was at Hinduja, no? You were Balki student, no?
Yeah, he was trained at Hinduja. Yeah.
An MD from where?
KM, Mumbai.
Acha, KM, Mumbai. When did you do your MD? Which year?
2013, ma'am. I passed out in 2013.
Okay. I passed in 1993, MD. It sounds so long ago.
Just when I joined MBBS, madam. 1993 batch.
So he joined and I left. And Dr. Jyotsna was my assistant professor, associate professor that time. Yeah? So my unit had.
I was a student in Dr. Medica's unit, and Dr. Oak and Dr. Karnad were in the opposite unit. So all
I was in that opposite unit. I was in that
all our
opposite
exams were being taken by them. I remember.
Yeah, Dr. Jyotsna and Dr. Karnad both were there, but they just become associate professors. Then I think later Dr. Jyotsna left for Sion Hospital. Yeah.
Yeah.
And Dr.
Where she was
Medikar,
my MD guide again.
Yeah, acha.
So,
yeah. Dr. Yojana has come. Yeah.
Hi.
yeah, madam.
Hi, ma'am. Good morning.
Good morning. Good
madam.
morning.
Good morning,
So do
ma'am.
we start? Yeah. Hi.
Yes,
Hi,
yes.
Sunil.
Hi.
Start. Yeah.
Hi, Dr. Kavita.
Hi. Sunil, you can introduce, then we'll start. And
Yeah.
once Dr. Shankar joins around 12, he's got the Army Day parade. So then we'll, till then, if he's a little late, we'll continue, say around quarter to 11, 12, quarter to 12, 12. And then
Sure,
at 12, he will join us.
Yeah.
Over to you.
So, very good morning to all of you and happy Makar Sankranti. I
to
hope many people join in because must be a busy day for everyone. But we will get started. So for today's, which is the second of our MRA Student Teacher Interface, we have Dr. Shweta, who's a fellow in rheumatology from DY Patil, Pune, and she will be presenting the case on connective tissue disease with Raynaud's. And to take her through, we have our experienced moderator, Madam Yojana Gokhale, professor and internal medicine and rheumatology from Sion Hospital, plenty of experience. And we also have Girish, a talented rheumatologist. Now he is practicing at Pune. So Shweta, you have the case ready with you with your slides, and you can start. And then
Yes.
we'll take you through. And then in the second session, we have an excellent lecture from Dr. Shankar at around 12. So we can start.
Good morning, everyone. My name is Dr. Shweta. I'm a fellowship resident from DY Patil under Dr. Varshana. So today I will be speaking upon the connective tissue disease with Raynaud's phenomena case. My case is Miss BB. She's a 30-year female to our OPD with the history of initially small joint pain, which was symmetrical, 6 years in onset, with whitish coloration and blanching of the distal cortical for last 6 years. She also had spots on the face, palms since last 5 years, along with breathless walking 2 floors since last 5 years.
Shweta, sorry to disturb you. Sorry, just hold. There's some background noise. I don't know. Maybe except for the moderators, the others can mute themselves so that we can minimize this background noise. Yeah, Shweta, you can continue.
She had breathlessness on walking 2 floors since last 5 years. Difficulty in swallowing food since last 5 years. Along with that, she presented to us with protein since last 2 months and blackishness of index finger and thumb of the right hand since last 1 month. History of present illness. Patient was apparently all right 6 years back and developed pain in her small joints. These were insidious in onset, symmetrical, with swelling in the small joints at the MCP PIP wrist with early morning stiffness, which was around 30 minutes 6 years back. She also had whitish and bluish discoloration of digits on exposure to cold since years back. Along with that, after a year, she developed reddish small spots over her face and palms. These spots were non-tender, non-progressive since last 5 years. These are not aging on exposure or cold. She also noticed breathlessness on walking few meters and walking uphill since last 5 years. Since last 5 years, breathlessness is not increasing. Patient has difficulty in swallowing food and liquid since last 1 year. She also she developed this since 5 years. In 1 year back, she had symptoms of nausea, vomiting, which were more for solid than for liquid, but now symptoms have subsided. She also complains of frothy urine since last 2 months. There is no burn, no change in color of the urine. Along with this, she has blackish discoloration of the right hand index finger and thumb since 1 month, which is 2 centimeters at the distal end of the fingers, having minimal watery oozing at the edges, non-foul smelling. She also had pain around the distal edges. For the MR complaints, initially she showed to a local physician 6 years back, and later on she was referred to a rheumatologist 6 years back. She was started on treatment with 1 tablet once a week, but she was non-compliant to the treatment, and she presented to us with digital ulcers and frothy urine. There was no history of fever, cough, cold, epigastric pain when she presented to us. There was no history of recurrent oral ulcers, dryness of mouth, eye, recurrent dental infection, no history of giddiness, loss of consciousness, irrelevant talk or any seizure disorder, no any comorbidities, no any addiction. These were the picture of the patient. So you can see the small reddish spots over her palm and over her face, along with blackishness over her index finger and the thumb, with greenish line and oozing present.
Hello, Shweta. Did you ask for history of tightening of skin specifically in her?
Yes, ma'am. Tightening of skin is present since last 5 years.
Yeah. So you could have mentioned that. Yeah.
So, to summarize, she is a 30-year-old female with the complaints of breathlessness, difficulty in swallowing, reddish spots over her face and over her palms, with history initially of small joint pains and tightening present, and now presenting
So what?
with
So what did you
ulcers.
find on examination in the patient? Yeah, you told the history twice. What did you find on examination of the patient?
On examination, patient with temperature being normal, pulse being
There is a lot of
82
background noise.
on
Is
the side,
everyone using a headphone? A lot of background noise. Hello?
Can someone please check the audio? I think we are hearing a lot of noise apart from the presenter.
Go ahead, Shweta.
On examination, patient was vitally stable, temperature being normal, pulse being 82 beats per minute, equal on both the sides, BP being 126/76, saturation being 96 on room air normal, with a normal respiratory rate of 20 per minute. She has telangiectasia over her face and her palm, digital gangrene of right hand index finger and thumb, demarcation seen, greenish black in color, oozing is present, skin tightening is present, no cyanosis, no lymphadenopathy, no any photosensitive rash at present. In systemic examination, patient conscious with a normal cardiovascular system, no murmur is heard, RS being air entry being equal on both the sides with bilateral.
Was P2 loud?
Over the lower zone.
Was a P2 loud?
No, ma'am, there was no loud.
Okay.
No, ma'am, there was no loud P2.
Yeah.
Per abdomen soft, non-tender, bowel sounds heard.
What did you find on hand examination? Just tell only hand examination.
Ma'am, on the hand examination, initially there is a reddish spot, reddish small spots present over both the hands. Then over the right hand, the index finger and thumb, there is on the index finger there is blackening present, and on there is greenish.
The spots were blanching, right? The spots were blanching.
No, the spots, yes, ma'am. The spots are red blanching, ma'am. Minimal blanching is present, ma'am.
If they were not blanching, what would you think of? If they were not blanching?
Ma'am, usually these are telangiectasias, ma'am.
No, so if the telangiectasia would blanch, but if they were not blanching, what would you think of? That's the question. Which all red spots, when you see red spots, what do you think of? What all differential diagnosis comes to your mind, and then you check whether they are palpable, not palpable, blanching, not blanching. I think I've given half the answer. Okay, go ahead. Go ahead. Does purpura blanch? I can't hear.
What happened?
Hello?
I think some
I
problem.
think she is having some problem connecting.
Yeah, the share screen, I think, again, stop sharing and share it again. Your screen is lost. Shweta?
I think she's having some connectivity issues. I'll just talk to her. Yeah, she's just re-logging in now. Yeah, we can see you. Can you share your screen again? Shweta? Can you hear us?
Yes, ma'am.
Yeah, just share your screen again.
Sorry, ma'am.
Good.
Yeah, just go to the slide that you're using and then answer Dr. Yojana's question after that. Huh? Yeah, you finished examination findings. Stop there and answer the questions.
Yes, ma'am. Patient is conscious to time, place, person, cardiovascular being normal, RS bilateral air entry equal with creps present at the basal areas, soft, for abdomen being soft, non-tender, bowel sounds normal.
Any specific details you would like to tell about the crepitations?
Ma'am, basically she had Raynaud's phenomena present since last 5 to 6 years. Along with that, she presented to us with toddy urine and gangrene of the right hand, index finger and the thumb.
I think you probably didn't hear me. Would you like
specific.
to tell little more about the crepitations?
Respiratory findings.
Crepitations were over the basal areas. They were very minimal, with air entry being normal, and Velcro type of crepitations were present over the basis, ma'am.
Okay, fine. Go ahead. Go ahead.
So differentials being, my first differential would be systemic sclerosis. The positive things would be that she had Raynaud's phenomena. Along with that, she had telangiectasia. She had difficulty in swallowing and she had sclerodactyly. Negative points.
Did she have any proximal
initially
scleroderma as well? Did she have proximal scleroderma as well?
No, ma'am. Proximal scleroderma was not present, ma'am. It was very limited type of scleroderma she had.
So she had only
non-progressive, ma'am.
She had only sclerodactyly Can you show the face of the patient picture?
Yes, ma'am. Scleroderma along. Yes, ma'am. I'll show you the picture. Along with mouth.
Did you look for any eversion of the lower lid sign? Okay. Was there skin tightening on the forearm?
Oh, ma'am, not only forearm, it is there on the fingers, ma'am, and mouth
On the
reduced,
chest
ma'am.
wall? On the
With
chest wall, was there
the
any on the chest wall? No, just below the neck. Was there any skin tightening?
no, ma'am, there is no skin tightening at the chest wall, ma'am.
Okay. What all findings you want to look into hands in any rheumatology case? Forget this case. Any patient,
Ma'am,
when you're looking at a patient's hands, what all things you want to say? Raynaud's is one thing which the patient has. What all other findings or information that you get on examination of hands in rheumatology or in medicine for that matter?
ma'am, initially, ma'am, we see for the swollen joints or the tender joints.
Okay.
And with
So you
that,
look for if there
we
is any arthritis, swollen tender joint. Done. Raynaud's, swollen tender joint. What else?
along not along with that, we see digital fitting if there is any digital fitting present
Okay.
over
Okay.
the
Digital
distal
pitting.
areas
Yeah.
along the nail.
Mm-hmm.
After that, we see any
Mm-hmm.
deformities for rheumatoid arthritis.
Mm-hmm.
Then we see over the parts if there is any spotting which is present. Then we see for if there is gangrene, and if there is any gangrene. Then if it's only one finger on unsymmetrical, we will see if there is any carpal tunnel syndrome type of involvement which is present. Then tightening of the skin for sclerodactyly, we will see.
What carpal tunnel thing will you get?
Ma'am, there distal one or two finger, ring finger or the middle finger which is involved, there is asymmetry, ma'am, present. And there is twisting
Asymmetry of what?
deformity which will be
Asymmetry of
present
what?
in carpal tunnel, and it will be mostly asymmetry. Ma'am, it will not be present bilaterally. Carpal tunnel usually presents with one hand only, ma'am. And there is
Why patient
entrapment
cannot
type of
have
twisting
bilateral carpal
deformity which is
tunnel?
present only.
Why patient cannot have bilateral
Ma'am,
carpal tunnel?
they can, but usually they might present with only unilateral.
What typical history do you get in a patient who has carpal tunnel syndrome?
Ma'am, there will be pain, and there will be stiffness present, which is there throughout.
No. What all signs you get in a patient of carpal tunnel? On hand? What is Tinel sign? I mean, I don't want you to know the
The
names, but
flexion
if you know the sign, do you know there is something in which you tap the nerve that you're examining?
Yes,
Where do you tap?
yes.
Where do you tap?
Ma'am, over the, I'm not able to recall, ma'am, but I guess over the elbow.
Over the elbow. Which nerve is there at the elbow? In carpal tunnel, which nerve is affected?
Ulnar.
In carpal tunnel, which nerve is affected?
Medial.
Go ahead with hand examination. What do you get in the hand examination?
Ma'am, digital fitting, scarring, ulceration, then we check for the pulse if they are feeble or they are well felt. Then
Anything you look for in nails of a patient, nails and area around the information that you get in a rheumatology patient?
Nail fold capillary examination, ma'am.
Okay. But if you don't have a nail
We
fold
do
capillary
a nail fold
examination equipment, then just looking at the nails and the nail folds, do you get some information? Can nails be affected in some arthritis?
Yes, ma'am.
Which?
Psoriasis.
Okay, so what do you find on the nails in psoriatic arthritis? What all findings?
Is present.
Sorry?
Pitting, you see pitting, small pitting. Then
Where do you get, in which condition you get periangal erythema? Go ahead. Go ahead.
You finish the findings. Now go on to your provisional diagnosis, investigations and all. No?
The another DD I would like to keep is mixed connective tissue disorder along with scleroderma predominant. Positive findings being joint pain, breathlessness, Raynaud's phenomena, telangiectasia, difficulty in swallowing, and sclerodactyly. And third, I would like to keep as that overlap syndrome, scleroderma plus SLE overlap syndrome, since he's presented with polyurine and proteinuria.
Did you look for palatal ulcer in this patient?
Yes, ma'am. She doesn't have palatal ulcers, ma'am.
Can you describe a palatal ulcer? Palatal ulcer that you get in SLE, can you describe that?
Ma'am, they are over the hard palate. They are blackish brown in color over the hard palate and
Blackish brown ulcers. Why would they be black?
They are over the hard palate.
Why would they be black?
What
would a black ulcer indicate?
Vasoconstriction and
how much is a pain element in these ulcers?
oh, ma'am, there's a lot. The pain is present, ma'am. They are painful.
No. Did you look for muscles in this patient? You giving differential diagnosis of MCTD. What was the muscle examination in the patient?
Ma'am, there was no proximal muscle weakness.
How did you look for?
Ma'am, we made her to do the sitting and squatting position. We checked her power over arms for the shoulder joint and for the elbow joint flexion extension.
Okay. Good.
On its further evaluation at HB on present concern with counts being 10,200, platelets being 2.86. The renal function and the liver function test were normal. Urine routine showed proteins 2+. There were no percents. Stool OB was positive. We further evaluated her for RF factor and anti-CCP. Both were negative. Then ENA was 1:320. CPK levels were sent. They were 942. Blot was sent, which was UNRNP SM positive. Complements were normal. Further, we evaluated her with the OGD scopy since she had difficulty swallowing 2 or 3 solids, which showed smooth narrowing of the distal esophagus and proximal dilatation along with strictures. 2D was done. which showed EF of
Along with what?
55%.
Along with
RVA
strictures. Along with
2D course, ma'am.
OGD scopy, what did you say? Along with narrowing of the esophagus, distal esophagus, dilatation, along with what? Sorry, go ahead. Chalo. Some again connection problem.
Ma'am, can you hear me, ma'am?
Yeah, I can hear you. Go ahead.
Hello.
But we can't
Go
see
ahead.
the screen. We can hear you, but we can't see your screen.
Ma'am, is it visible now, ma'am?
Now we can
Yeah,
see.
now we are seeing.
OGD scopy being smooth narrowing of the distal esophagus and proximal dilatation of the distal of the medial part of esophagus along with stricture at the basal areas were present. 2D echo EF being 55%. There was mild pH with RVST being 35 mm of Hg. We further did her HRCT thorax suggestive of multiple tiny small nodules with surrounding gigios with ILD was present, NSIP pattern. PFT was done, FVC was 1.74, 68%, mildly reduced, FEV1 being 1.45, 67%, but the ratio was normal. Barium swallow was done, which suggested of smooth narrowing at the distalmost thoracic esophagus, likely being benign intramural cause. We further did her a bilateral upper arterial Doppler, which showed diffuse circumficial wall thickness in bilateral upper limb radial ulnar artery and the palmar arch. There was right second artery suggestive of vasoconstriction.
Would it be important to mention whether this patient had any vegetations? Would it be or would it not be?
Yes, ma'am.
Why?
It would.
Why would it be?
Ma'am, since we are seeing sclero and since we are seeing that there is pH, usually in systemic sclerosis, we have a right heart failure component, ma'am. So, along with that, we are saying there is Raynaud's phenomena. So, if there is any embolic event which is present for that, then if it is not
See, Raynaud's
related
is
to
there for
rheumatic, then
6
we'll have
years,
to
dear
see if there is
Shweta.
atherosclerosis or
Shweta, this patient is having Raynaud's for 6 years, right? Isn't it?
yes, yes, ma'am.
Then why particularly now echo would be important? And in
Ma'am, now
echo,
since
vegetations, whether they are or not, would be important now.
ma'am, now she has come with ulceration, which are acute since last
Now she has
1
come
month.
with gangrene. Can there be a thromboembolic phenomenon that can give rise to gangrene?
Yes, ma'am.
Go ahead.
Management. So initially, since last 5 years, she was initially started with polytrack.
One sec. What was the cause of stool
week.
occult blood positivity?
Ma'am, one of the cause can be gave or she is
what disturbance? Some cross connection is there? या कुछ तो advertisement चल रहा है भाई.
Yeah, once again, I request all the other participants to just keep themselves on mute mode, because then it causes a lot of disturbance and it disturbs the flow of the case. So please. Yeah, Shweta, you can continue now.
stool local blood can be positive in sclero, ma'am. We are saying it can be systemic sclerosis, one of the BDs. So it can be, ma'am, because of GAVE which is present.
So did she have GAVE? Did she have GAVE?
Vascular ectasia.
The scopy was done. There was no GAVE, right?
No,
was there GAVE?
There was no GAVE. So one of the causes.
Okay.
No, ma'am.
One of the cause could be GAVE, right? What is GAVE exactly? Can you give the full form of GAVE?
Gastric esophageal or gastric vascular ectasia. So
okay, what is the treatment for it?
Gastric vascular.
Yeah, right. What is the treatment for GAVE?
Ma'am, the treatment we usually for these patients channel blockers. There is no specific per se treatment which we.
No, there is a very specific treatment. There is a very specific treatment. There is a very specific treatment for GAVE. There is a very specific treatment for GAVE, Shweta. It is not like any other esophagitis or gastritis where you give pantoprazole and leave. There is a very specific treatment for GAVE.
For ablations or ablations, laser ablations for GAVE.
Yeah, go ahead.
You can go for ablations, ma'am, in GAVE.
Yeah, photocoagulation. Come on, go ahead.
The management, ma'am, we started her on mycophenolate mofetil, ma'am, 360 2 tablets, Dalafil, 2 tablets in the morning and the evening. We later added bosantan in the night. Along with that, steroid was started. Steroid was ongoing for her. Along with that, we had given her Ramicil once a day, calcium channel blocker, nifedipine twice a day, and aspirin. And use of mittens, ma'am.
Now, do you think this particular patient has scleroderma SLE overlap, right? The kidney involvement is because of?
Ma'am, there are very less chances of she having scleroderma SLE. The only reason was proteinuria was present, ma'am. Initially, which was not present. Initially, since we started with the disease for last 5 to 6 years, it was not present. But since last 2 months, there is proteinuria being present. So that is
so
one
what
of
could
the
be the
reasons
cause of
she might have,
proteinuria?
ma'am,
What could be the cause of proteinuria? What was her anti-DHDNA, anti-Smith?
Ma'am, can you please repeat, ma'am?
What was her anti-DHDNA, anti-Smith status?
Ma'am, anti-Smith was positive, ma'am. Anti-DHDNA was negative.
No, is anti-Smith specific for SLE?
No, ma'am. It is not specific for SLE. She had O52 also positive.
Okay, so anti-Smith is not specific for SLE. Which antibodies are specific for SLE? Can you just enumerate the antibodies which are specific for SLE?
Ma'am, it's a Rho52 anti-Smith.
You said anti-SM is anti-Smith or anti-smooth muscle?
Ma'am, anti-SM is anti-smooth muscle. Anti-Smith we didn't do, ma'am. DSDNA was negative.
Why anti-Smith was not done? Any reason? Should it be done or it should not be done?
Ma'am, it should be done.
Why should it be done?
Ma'am, if we are thinking of overlap syndrome, then to be more specific.
How often you would get, say, proteinuria in a patient of scleroderma? Is it common or uncommon?
Ma'am, overlaps are not that.
No, I'm not talking of overlap. Lupus, when you're saying lupus, or see in a patient of say proteinuria of 3+, proteinuria 3+, is it common in scleroderma?
Ma'am, am I audible to you? Hello.
I can hear you. Can you hear me?
Hello. Ma'am, am I audible to you?
Yes.
Sorry, ma'am.
You can answer ma'am's last question, Shweta.
Ma'am, actually, I have just some internet issue, ma'am.
You could hear madam's last question. Is proteinuria common in scleroderma?
No, ma'am.
Madam was asking. Such heavy proteinuria, is it common in scleroderma? Madam asked.
Then scleroderma, ma'am. Sorry. Proteinuria, ma'am, it's more common.
Say yes or no first and then answer whatever you want to answer. Which all connective tissue diseases you get involvement of the kidneys and in what form? Hello, Shweta.
Madam, if I may, if Shweta is unable to having some issues, then I am sure there are other participants, and I think one of the participant can answer Madam this particular question while Shweta manages to join in. If that's okay with Madam, then
Yeah,
one
yeah,
of the
fine.
rheumatology,
Absolutely.
yes, yeah. Any one of you there willing to answer, please come ahead and answer this particular question. Meanwhile, Shweta will join.
Shall I repeat the question? Is it common to get proteinuria in patient of scleroderma? Question number 1.
Dr. Deepti, you can answer.
Are you there, Deepti? Lakshmi? Shweta is joined back.
Sorry, ma'am. I just
Could you
some
hear
internet
anything,
issue.
Shweta? Proteinuria
Hello?
and scleroderma, madam was asking you.
Hello.
Hello, can you hear Shweta?
Ma'am, sorry, I have some internet issue.
Dr. Girish and Dr. Yojana, I think we can, Dr. Shankar has already joined. So you can ask some questions or sum it up, like, like a feedback. And then we can start Dr. Shankar's talk after some time.
Yeah, Dr. Girish, summary and
Yes, ma'am.
comments.
I think presentation was good, but overall, few things need to be improved, especially like about carpal tunnel syndrome. She could not answer about that properly, and you should read about the last question was important: the kidney involvement in connective tissue diseases, and whether it is common in scleroderma, and if proteinuria is present, whether what could be the causes. So overall, it was good, but need to work out on few things.
Dr. Yojana, your comments?
I think she really needs to work on many things. Basics really need to improve, like which all, I mean, in a particular connective tissue disease, what occurs and what doesn't occur has to be known to people who want to pursue rheumatology. So if an unusual finding is found in a particular case, one has to consider additional diagnosis, and especially when DD is mentioned, like overlap of SLE and scleroderma, then she should have been ready with what all things can happen to the kidney in the overlap or in SLE scleroderma. I would say that really a lot of improvement is required in this presentation under basic concepts.
Okay. Any other faculty would like to give their comments? Dr. Sunil, Dr. Varsha?
Yeah, Shweta, I think last few points you could not catch what ma'am was asking you. So you need to work on those because you already put the differentials there. Overlap syndrome of scleroderma with SLE. So why, this kind of proteinuria is happening in this patient, etc. So just work on that. Also a few more questions which madam had asked you before. No, find the answers to that. You know the answers. I don't think there's a problem, but you have to be ready at that time, right?
Yeah. Whatever differentials you prepared, you should have points in favor and against. That makes it simpler to answer, 1, 2, 3. So that you should keep it prepared always. Yeah? Okay, Dr. Sunil, any other comments?
No, ma'am, that's fine. I think I agree with whatever everyone has said. So we can proceed with the next talk.
So Dr. Shankar, are you there with us?
Yes, Dr. Kavita, I am very much here.
Yeah, so I take great pleasure in inviting Dr. Shankar. He's the Air Vice Marshal at Command Hospital, Bengaluru, former professor and head Department of Medicine, AFMC, Pune. I have known him for many years, and his academic credentials, his zeal for teaching is like immense. Like it never ceases to amaze me. So I thought he was the perfect speaker for this platform. And he has multiple publications, awards, and he's always full of energy. And he's such a fantastic teacher. And in our MapCon, we had a standing ovation for him. That was really awesome. So today we have a very interesting talk by him. The topic is how to read a research paper or a landmark trial, which is very important for students and also all clinicians. So over to you, Dr. Shankar. Thank you so much for joining us.
Thank you. Yeah. Thank you very much, Dr. Kavita. Can you see the screen?
We can see the slides. Yeah.
Wonderful. So thank you for this lovely opportunity. And I'm going to cover the entire thing. I just going to talk about two things today. The context on why we should know how to read a paper and the process. That is, how do we go about doing it? And I shall try to share some easy thoughts on it so that it's easy for us to remember. So the first 1/3 of the talk will be on why we should know it. The context actually comes under the broad basket of what we all know as evidence-based medicine. If you ask what is the evidence-based medicine, it has got three components. It is essentially nothing but a decision-making tool which we use to choose any kind of a diagnosis or treatment for our patient, which is based on three components, namely evidence, combined with the expertise of all of us and the expectations and values of patients. On the right side, you see a book which is an absolutely must-have by Dr. Kameshwar Prasad of AIMS, Fundamentals of Evidence-Based Medicine. I have sent a soft copy to Dr. Kavita by email, a PDF, which I will request her to share with all of you after this talk. And this is such a brilliant book. It just costs about 200-300 rupees in Amazon. I would suggest, please, it's more than worth its weight in gold. If you look at evidence-based medicine, just remember 4 numbers: 1, 2, 3, 4. There is one goal of evidence-based medicine, 2 fundamental principles which underlie it, 3 components, and 4 steps to do the same. The one goal is very simple. It is to improve the quality of clinical care that we provide to patients. Or if I have to paraphrase it, it is to improve the health of people through decisions that we make that will maximize their health-related quality of life and lifespan. It has got 2 principles. We are aware of the first one, that is, in the evidence, there is something known as a hierarchy that exists. The hierarchy is determined by the freedom of error. So, for example, if you look at a meta-analysis of multiple large randomized controlled trials, that would possibly be right at the top of hierarchy, with the least amount of error. And as we come down through RCTs, observational studies, clinical experience, and basic research, the probability of error in our decision making will keep increasing. But it is the second principle which is not often discussed, that evidence alone is not enough. In fact, it is insufficient. So the question which comes is, if evidence alone is not enough, what is? And which brings us to the 3 components, that it is actually the entire decision making is based on 3 things, namely evidence, expertise, and expectations of patients. For example, let us say there is this young PG resident who comes and he sees a patient with quadriparesis and difficulty in swallowing, and he makes a diagnosis of Guillain-Barré syndrome, and he's already prepared the importance of IVIG, and he has got himself totally worked up on the various evidence of IVIG, and he's going to make a presentation to the professor. The professor comes for the round, happens to be an expert, and while he agrees with the findings, looks at the patient and specifically asks the relative whether there was any dog bite. And the patient does remember that, yes, there was a dog bite 3 months ago. And immediately the diagnosis shifts from Guillain-Barré syndromes to dumb rabies, and the patient is sent to an infectious diseases hospital. So all the evidence is worthless if it is not tempered with expertise. Looking at the expectations of patients, if you see, the cost of treating rheumatoid arthritis with methotrexate translates to about 5 to 10 rupees a week, just the cost of methotrexate. So maybe less than 500 rupees a month. And the resident is jumping with joy at the role of infliximab, which is so much superior to methotrexate. And he says that it causes an ACR 70 response in so much percentage versus so little in methotrexate. But then the consultant looks at the patient and says, what is his monthly income? And the patient is a daily wage laborer who does not have medical insurance, and the patient's earning is only 9,000 rupees a month. Therefore, despite the fact that infliximab and etanercept might be superior to methotrexate, it is stupid to even suggest the word etanercept or infliximab to a daily wage laborer. So one has to temper the treatment with expectations of patients. So your entire decision is based on a tripod of evidence, expertise, and expectations. Once you decide to look at the evidence, you take 4 steps. The first is you have to, now that all of us are consultants and those of you who are doing your super specialty, you must start asking the required information by formulating your question. For example, in the next slide, I shall show how a question gets formulated, and only then you must figure out how to acquire this information. Actually, this entire talk is actually a 2-day affair where on each one of them, it's a topic by itself, but I shall try to summarize it quickly. It is at the 3rd step that you assess or appraise the relevance, quality, and importance of information. And lastly, take a decision on how you are going to apply the information in your practice. The way to ask a question is in the format of PICOT, P-I-C-O-T. Let's say you want to know how good is heparin in stroke. Now the question would be, you have to be very clear in which stroke you're asking. Clearly, you're only asking for it in a thrombotic stroke and not a hemorrhagic stroke. Number 2, patient with rheumatic fever with atrial fibrillation can also have a stroke. You are not interested in that subgroup. So you are possibly only looking at elderly people without atrial fibrillation. So that would describe your P, that is patients. Then you would like to look at a study which looks at an intervention where you would say, okay, I would be interested in knowing whether heparin is superior to aspirin or placebo. And here you may have to take a decision. Is it only the unfractionated heparin or any type of heparin would do? So you would have to write that down. That is your I. Your control, you would have to take a priori decision whether you're going to look at a study which is comparing it with aspirin alone or with a placebo. That is your control. You would have to ask, what is the outcome you're looking at? Are you looking at a recovery from stroke? That is, till a person becomes ambulant, or are you looking at a risk of relapse? That is preventing the second stroke. That's a different question, different outcome. So you have to define your outcome. And lastly, you have to say over what time. Are you looking over a period of 1 month, 6 months, or 1 year? So let us say you decide in this, you will decide to choose a study which says, I am looking for role of heparin of any type amongst elderly patients without atrial fibrillation in compared with aspirin / placebo, so that for a period of 1 year and looking at recovery to the extent that the patient is completely ambulant. And then you should start searching for literature. When you go to the second component, acquire, you are in a big trouble. We have more than 30,000 medical journals. Between them, they publish more than 2 million articles annually on many thousands RCTs. Last count, it was told 55,000 per year. The sad part is, depending upon which critic are you seeing and which journal you're reading, 90 to 99% of all the published articles are deeply flawed. So your position is something like this farmer who has to separate wheat from the chaff. Your challenge actually is to distinguish genuine research, which should actually inform your practice, from the poor quality endeavors of well-meaning amateurs, whom you should politely ignore. Now, if you do not have this ability, there is a 99% chance that you will be reading garbage throughout your life. So if you see, today's topic is essentially the third component of the fourth step. That is, we're only talking how to assess or how to read a paper. For this, there is a second book which I have given to Dr. Kavita. This is one of the best books by Dr. Greenhalgh. This is the 4th edition. I've sent a soft copy, again worth its weight in gold, and I would advise all of you to buy this from Amazon. Just cost 300 to 400 rupees. And this will teach you, these 2 books will teach you more about evidence-based medicine and how to read a paper than possibly any other source. But a soft copy will be available with you by the end of this talk. Before, I will be running you through a landmark paper, but before we get into the technicalities, we have to ask ourselves 4 fundamental questions about a landmark paper. The first one is this relevant? Second, is this valid? Are the results consistent? And is the result important or significant to me? So what do we mean by relevance? It is the extent to which the research paper matches the information that you asked. You see, in the beginning, you will be running through a few random journal clubs and understanding how to assess a paper. But eventually, when it's on a, you see, the most important thing is the time and the attention that you can give. This is a finite and limited resource. If you are capable of reading, let's say 1 to 2 articles a week at max. So those 1 hours have to be reserved for the best papers. So you need to write down your PICOT in a priori. You should write it in beginning that this is what I want to search. And then you should start searching PubMed or other things for their PICOT. You will be lucky sometimes and hit the bullseye, but you will be mostly lucky most of the times. With a little variation, by and large, you can search a paper of your choice. That describes the relevance of a paper to you. Just 1 second, please. One important call is coming. Yes, morning, ma'am. Navjot is seeing her. They will take a call whether they will be taking her up for an angiography right now or no, ma'am. I will keep you updated on this. She was actually right now in the middle of another PAMI when this occurred. So abhi usko stabilize kar rahe hain, and then Navjot will take a call. I'll keep you updated, ma'am. Yes, ma'am. Actually, already Sachin has reached the hospital. I'll be reaching in another 30 minutes, ma'am. Yeah. Yes, ma'am. Yes, ma'am. Right. I'm sorry. Yeah. Can you hear me?
Yes, we can.
Yeah, okay. Yeah, sorry. So the next question which you have to ask is this study valid? What do we mean by valid? Valid means the result should be free from bias. There are many types of biases, but fundamentally there are 3 types of biases: a bias in selection, a bias in measurement, and a bias in analysis. And we should not get too much into detail of this. In the example, things will become very clear. There are also 2 types of validity: internal and external. So the internal, you check whether the results are correct. Are they meaningful to the subjects in the study itself? That's the first question. Then you have to ask whether whatever it is, the results which have been told by the author, can I extrapolate it to a different time, place, in person? Can it be, it has been done in white Caucasians. Can I translate it into Indians in India? It has been done for young people. Can I translate it to elderly geriatric group? These are the questions which one must ask of ourselves. The third point is what is known as consistency. You would have to look at the various results across in the study itself and see whether all the results, whether they are doing an adjusted or an unadjusted analysis, sensitivity analysis, subgroup analysis, all of them, are they telling one narrative or there is a discrepancy between them? And you should also see whether this study more or less agrees with other similar studies, or even the other, the biological logic, is it agreeing with it? That tells you whether there's a consistency in the answer. And lastly, you will ask, is this result significant to me? How did the new test perform, and can I use it in my patients? All this seems a lot of theory. So let's take one landmark trial. I have taken a 2008 Lancet trial called Comet. Many of you might be familiar with this, which compared methotrexate monotherapy with a combination of methotrexate and etanercept in active, early, moderate to severe rheumatoid arthritis. It was a randomized, double-blind, parallel treatment trial. So in the next 6-7 slides, I will take you through the trial itself, and then I shall say how we can critically analyze it using a very simple formula. What this study claimed to do was it compared the remission and radiographic non-progression in patients. One group was given methotrexate, another was given methotrexate and etanercept over 12 months. This was done across 70 sites across 4 continents. It was an RCT, and they followed up the patients for 1 year. Like any other RCT, they took people more than 18 years of age. They had active disease, and they should not have taken previous methotrexate or DMRs. The first group was given etanercept and methotrexate, and the second was methotrexate with matching placebo. Everybody got folic acid, and a low-dose steroid and NSAIDs was permitted. They also had a co-primary endpoint. They looked at both clinical remission and radiological remission, and they blinded the entire process. So the primary outcome was number of participants achieving remission as measured by DAS28 at the end of 1 year. And those people were, at the end of 1 year, the modified sharp score progressed by less than 0.5. And as a secondary outcome, they looked at adverse effects. They did something known as a Hodgberg setup, which is done when you're doing multiple. It is a variation of Bonferroni correction, where you're doing multiple analysis. These are just statistical terms. Don't get perturbed by this. And they also compared the total sharp score between the treatment groups with something known as ANCOVA, analysis of covariance. They took 542 patients who were randomly allocated to group A or group B, 279 and 268. You can see about 53 people withdrew in group A and 79 withdrew in group B, so that eventually only 221 and 189 people completed 1 year of study. Like in all articles of Lancet and NEJM, the baseline characteristics were quite perfectly matched with an average disease duration of about 9 months. Here are the results. The authors found that at the end of 1 year, about 50% patients had achieved remission with etanercept plus methotrexate, while about 28% had achieved remission with methotrexate alone. Radiologically, if you see on the right side, about 80% of the people on etanercept and methotrexate did not have radiological progression versus about 59% with the methotrexate alone. Adverse effect was slightly higher in the methotrexate group. So the authors concluded that combination therapy is superior to monotherapy because more than 2/3 patients had achieved DAS less than 3.2. In 80%, radiographic halting of progression occurred. And they also did analysis of how many people could go more to work, and they found there was a 3-fold reduction in work stoppage. So, and they also did a post hoc analysis that 78 of the about 35% patients achieved clinical remission, radiographic non-progression, and normal function. So, all this looks really, really good. And a journal club of this nature in any medical college will come out with flying colors. Now let us see whether this is a good study or not. Let us look at it critically. Instead of mugging up, I think a picture is worth 1,000 words. And I would like you to, this is from New Zealand, and I follow this personally. That is a GATE approach, graphic approach to epidemiology. It's called the GATE frame. So this looks something like a skeleton, which is standing like this one with a head, a tummy, the two legs, and the left hand, which is kept in a kind of a funny way. So this is the shape of every epidemiological study. So just remember the gate frame. And there are two acronyms which I would like to remember. The first one is PCOT, which or PICOT, whatever you want to say. The P is who are the participants. E is the exposure group, or you can call it the intervention group. C is the comparison group or the controls. Then you look at the outcomes, and T is the time duration on which it was followed. And when you do, if you see in the gate one, every study is essentially looking at only one analysis. What was the outcome in the exposure group, EGO, versus the outcome in the control group, CGO? Every study just uses this one analysis because that is what is at the heart of any randomized control trial. For the critical appraisal, we remember the acronym RAMBO. You look at how was the recruitment done, whether the allocation was correct, whether the maintenance, people were maintained correctly, and whether the measurements done were blind or objective. So let us look at this study from this critical appraisal. If you look at the participants, I think it looks pretty good. They took early rheumatoid arthritis. It was a multi-centric trial across 4 continents, 70 centers, I think, and it was done by rheumatologists. So we can say this part seemed good. They also said that the people should not have taken methotrexate earlier, fair enough. And they managed to identify 542 patients with a mean disease of almost 9 months. So I think the participants looks quite good in this study. Then they landed up coming to, if you see, they had taken 274 people. Now, when you are putting this in, it's a good idea to start filling it up for practice. They took 274 people, out of which in the exposure group, only 221 finished 1 year. So there was a 19% dropout. And among the 268 people, they could only analyze 189. So there was a 29% dropout. This is a little worrisome. In any randomized control trial, if the dropout rate is 10 to 15%, it's okay. The moment it crosses 20%, you should start getting a little worried. So already this is number one point of worry, that there was a 29% dropout. And until you actually write it down, you will not instinctively be able to figure out how many people dropped out. So this is the first thing which we learned in the study. Next, we go to the outcomes. We know how many people achieved remission. We must fill up that out of the 229, you must exactly break up the number of people who achieved remission in the exposure groups and did not achieve versus those who achieved in this thing. Fill up the raw figures because this will tell you a lot of story. And 12 months it was followed up. This is very, very obvious. So no problem here. They didn't look at the incidence, they only looked at total number of, they were not interested in knowing at what was the rate of remission. Only at the end of 1 year, kitne logon ko remission ho gaya tha. Now with this principle, let us see how strong this study was. We asked what the recruitment processes appropriate to study goal. So the study setting and eligibility criteria seem well described. The randomization seems good. But there was one serious problem. When you ask these questions, and I'll come to that problem in the next slide, they capped the dose of methotrexate at 20 milligram max in the oral dose. As rheumatologists, we all know that methotrexate is absorbed only 65 to 70%. So effectively, they were only giving 13 to 14 milligram in the control group. Whereas all rheumatologists, and even in 2008, this was already a practice, we were started giving 25 to 30 milligram subcutaneous doses. So if you see, they had created a situation where the control group was given suboptimal dosage. Is it a simple error or is there more to it? It's very difficult to say. But if you actually look at it, this entire thing was sponsored by Wyeth, who has a interest in ensuring, whenever you want to show that something is very good, it is always a great idea to choose a terrible comparator. You want to show that a man is very rich, earning 30,000 rupees a month. Compare him with a beggar. The 30,000 rupees a month looks very, very rich. So this is one standard game which is played by many of the pharma companies sponsored trials, where they will do everything perfectly, but in a very subtle way. It would have been, if you actually see, it's so obvious now when you look at it in a very critical way, that why was only 13 milligram methotrexate given as a max dose. Needless to say, very few people are going to achieve remission. Also, we know the adverse effect, that is the vomiting, etc., is more when you take it orally versus when you take it subcutaneously. Now, by not permitting subcutaneous, they have actually ensured that lots of patients will get out of the study because of vomiting. So methotrexate will not only look ineffective, it will also look bad from the adverse effects point of view. So this is a very intelligent and smart strategy which is used by the pharma companies. In fact, they have lots and lots of brilliant scientists sitting down who are only doing this job on how to play a game under the radar. I wouldn't be surprised if most of the rheumatologists missed this point and they fell right into the trap of Wyeth. Now, rest everything is very clean in the study, where the participants maintained, fat books would be maintained where they say, yes, compliance was good, participants will be blind. They will not cheat anywhere in this point. Outcomes were blinded and objectively measured. No error there. I mean, you cannot challenge on the quality of ESR or quality of CRP or quality of tender and swollen joint count. That will be done by really top rheumatologists. Lastly, was the statistical done analysis done correctly? While it is correctly, but it is always incomplete. Most of these trials stop short at relative risk reduction because it looks nice and big. They do not calculate absolute risk reduction and number needed to treat. Though in this case, 50% people achieved remission with etanercept and methotrexate, while 28% were with methotrexate alone. So there was a 22% higher rate. And if you calculate something known as a number needed to treat, it is 100 divided by 22 or 4.5. So what the study is saying is, in reality, almost 4.5 to 5 people have to be given treatment to achieve one additional remission. There are two flaws in this. Give it a thought and just stay with me. Number one, if methotrexate had been given in a higher dose, that is 25 to 30 milligrams subcutaneously, instead of 28%, your answer might have been closer to 32, 33% or some slightly higher number. That would have translated to a much higher ARR would have reduced from 22 to have come down to 17% or so, and number needed to treat might have increased to 6 or 7 people, which would mean, now look at the cost. This is something which nobody touches. Definitely when a study comes from USA or UK, they will not touch money with a barge pole. But you as Indian rheumatologist, it is your duty to touch this. Methotrexate cost with folic acid per week is less than 10 rupees, maybe 15. Folic acid is the one which is more expensive. And methotrexate, therefore, at the end of the whole year, 52 doses, hardly costs 1,000 rupees or 1,500, maybe 2,000, depending upon which brand you are choosing. When you want to give etanercept, if you're going by MRP, it still costs more than 4 lakhs. And even if you negotiate a nice price with your dealer and you are one of those very sympathetic rheumatologists who likes to get the best price for their patients, it still costs about 1.5 to 2 lakh rupees, depending upon how much of a negotiation you can do. So here you are comparing 1,000 rupees to 2 lakh rupees. So and since you have to treat 6 additional patients, 4.5 to 6, depending upon how the analysis was done, you will have to spend 12 lakh rupees more to achieve 1 additional remission. You could have achieved 5 additional remissions just by changing it to subcutaneous. So here is the game which is played. The full spectrum has not been revealed to you. So let us go back to the 4 questions which we asked. Now that we have understood how to analyze the data using gate frame, Picot, Rambo, you have to ask these 4 questions again. Is it relevant? You must compare your Picot with their Picot. You were interested, let us say, in looking at early RA. This trial looked at 9 months. You are happy. You wanted to check, you wanted to see etanercept versus methotrexate optimal dose. They gave etanercept plus methotrexate. You don't mind it. You are very hung up on optimal methotrexate dose because you are a good rheumatologist. When you checked it, you were shocked to find that they gave a suboptimal dose. They kind of played the game of using a poor control. You wanted to check clinical remission. They have given you clinical and radiological remission. Fair enough. You are happy about this. You looked at 1 year. This guy said 52 weeks. It's exactly the same. So this is a fantastic study because your Picot matched their Picot. The next question you will ask is that, is it free from bias? And this here, you were really shocked because they overestimated the difference by addition of etanercept because they gave suboptimal methotrexate dose. So this whole study has got vitiated. You cannot trust the results. Were they technically consistent? Yes. Many other studies have showed that etanercept is good. So this also says it is very good. So the direction is fine. No problem there. Last question is it significant or important to you and will you use it? Purely based on this study, firstly, it's a very poorly designed study because you cannot use a suboptimal control. Choosing a control is a whole day's workshop by itself. And if you choose a poor control, you can change the answer of any study in the way you want it. And since the validity is poor, therefore, this study is not, you cannot use any of its results. I think that's how one should go about it. And I think I have come to the end of my talk and I would be very happy to take any questions.
Yeah. Anybody has any questions? Dr. Yojana, Dr. Rohini? I think, could you just unmute everybody?
No questions.
Sorry, Dr. Shankar, I joined a little late, some family commitments. Thanks for taking this talk for all our students.
Yeah.
So
I have also shared the 2 books with Dr. Kavita, and I think that this is not a very easy topic. It's also a very boring topic, actually. So
you made it nice.
It should become easier. That's all.
Yeah. I think even the outcome measures have to be relevant to the case. I mean, it's basically tocilizumab related trials where the outcome measures in most of the trials were death and the patients ranging from 2 liters of oxygen to, those on ventilator were recruited, no stratification in results. Same again in Pexiva's trial also, even though, I mean, it's difficult to conduct such a trial over 7 years, but then when you're doing so much hard work and if you don't, analyze your results don't do any subgroup analysis in publication. I mean, people really have to understand how to utilize that information that they get, especially one get carried away, NEJM में publish हुआ है, like same like Lancet में publish हुआ है. It doesn't really mean that what they have published is always right from scientific point of view, right from enrollment of patient to even outcome measures. So I really appreciate that this was brought out and the students should really learn to analyze things critically, read a paper.
And get over the hangover of the West. No?
Yeah, absolutely. Absolutely. Meaning, imagine somebody who is on 2 liters of oxygen, and the endpoint for that person is also death, outcome, and somebody who is on ventilator also outcome death. I mean, the outcome measures should definitely be different if you are enrolled patients with mild disease versus patients with severe disease.
Absolutely. Yeah. So the thing would be that when you hang it on the gate frame, these things become very obvious. Sometimes otherwise, if you don't, and that's why I like this Picot Rambo acronyms, they make it easier for us to analyze.
Or else we should be able to, do subgroup analysis ourselves. Those with, like, say, a Pexivas trial, patients with creatinine 5.5 also, like, no Plex doesn't work. And then patients like with a creatinine of 2.2. I mean, anyway, you're not going to use Plex for them. But, and especially when such trials are conducted over 7 years, I mean, nobody's going to repeat that trial. Something which is done for a year, maybe somebody else will repeat it. 7 years requires too much of planning. And then if the results are, at least subgroup analysis should be published, or when any journal like, say, NEJM is publishing, they could easily ask for, include subgroup analysis. If similar trial is going to come from India, it would be straight away rejected. But here, like, start wondering whether the sponsors are having any interest in their own product to promote it, or by saying that a particular
you are right.
procedure.
In fact, that is what makes the problem so much more, because almost 90% of the trials which get published have got deep methodological flaws.
Yeah.
So we have to, but then you can't throw away the diamond along with the coal also. You have to know which is the diamond. So we can't, therefore you can't look at every person, every trial and say it's bad. So
right.
that is
so
also
you
wrong. So
have a critical
we
outlook.
need to sharpen our ability to be able to look at all these things critically and identify which are the great ones and which are the ones which are not so great. That's it.
Yeah. Nice. Yeah. Thanks, Dr. Shankar. You're always good.
Yeah.
Thank you.
Thank you so much. For our students, it was like a new insight into reading an RCT, some beginning at least, So thank you so much for joining us. It was Army Day today. He went to the parade, he came back. Now he has to rush again for some emergency. So thank you so much. I will share the books with the students today.
Thank you. Yeah. Thank you, Dr. Kavita, for the opportunity.
Army Day is because General Cariappa's birthday or something. I mean,
no.
It is no. When he,
no, I don't think so. No, it's nothing to just. Let us find out. It's a good question. I don't know why it's Army Day.
I think it is. I think it is. I think it is General Cariappa's birthday that is celebrated as Army Day. Yeah.
So that's homework for all of us. We'll find out.
Okay. Right, ma'am. Bye. Thank you.
Thank you so much. Yeah. Dr. Roni will close. Sunil will close the meeting.
Yes, madam. I think we can close. Just one point I had. I mean, I think the other students need to be there.
Yes.
And they have to participate. And I think it's quite fair from next time, if the moderator wishes, I think we should just randomly pick up one name of participant.
You know what happens? The random students remain silent. So I'm going to put 3 students' names now from next time.
Yeah, that would be better.
One is going to present, and the other two are also going to answer. So at least 3 will compulsorily be there.
That's a good idea, madam. That's a good idea.
Yeah, that's really good.
Yeah. And even for our guest speaker, the topic that we have chosen is primarily meant for the students. So there should be some form of interaction. If they have learned, if they have got something, some comments, something should come. They are all post-MD students. So I think they should be communicating. That's what I feel in today's
session. So how we have multiple chairpersons, we'll have 3 students. I think primarily one will let them get extra turns, multiple turns in the year. That's fine.
Yeah, that's true.
Good.
Yeah.
Thank you.
Any other suggestions?
Yeah, I think that questioning thing, the students feel that they feel a bit
inhibited,
hesitant, but they should not feel actually. They should feel In fact, asked maximum number of questions should come from them.
Yeah, so then there'll be more teaching also, no? If they answer, then, they don't open their mouth, then how to go on, you know? It's like that, yeah.
Yeah,
Okay.
nice. Okay. Thanks. Thanks, Dr.
Thanks, Kavita.
Yeah.
You're doing a
Bye,
good job, and Sunil and
Yeah.
Girish as well.
Yeah.
So
So
continue
we
the good
plan
work.
for next month also. Next month guest lecture
Sure.
is by Dr. Avinash Jain on qualitative
Okay.
research, and case presentation is Dr. Rohini, I think your student, no?
Girija, yeah.
Yeah, Girija. So you will give the case, and I'll allow
Okay,
2 more
fine.
students now. She will present, and I'll put more names.
Right.
on it. Yeah.
Right.
Yeah. Okay. So I think, hello.
I
Yes,
missed
Can
the
I suggest
case because
Yeah, they should
I-
tell the case to the other 2 students well in advance so that they at least read and come, you know.
Yeah. The case is on the group since last,
Right.
last 1 month, actually 4 weeks.
Okay.
I had put
Okay.
the topic like it will be CTD with Renault. So last
Yeah.
time they asked for it, so I gave it to
Yeah.
them. I
Okay,
think they're a
fine.
little intimidated or what they're scared to answer. I don't know. So we'll keep 3
see,
names.
it's your forum because as you know, your inputs come in, the thing can improve, the program can improve. So
Yeah.
your participation is important.
Yeah.
By the way, I'd gone to Juhu Beach and missed the first part with the baby, and it's nice to tell you all that it's quite clean and
Okay.
I mean, reminded of all my childhood days when we used to go a lot to Juhu Beach.
Yeah.
So with my grandchild, I had gone, so it was fun.
Okay.
Yeah.
So we'll visit the clean Jew Beach next time. Yeah.
It's much cleaner than what it used to be in between.
Great. Okay. Chalo, happy
Okay,
Sunday
Kavita.
everyone. Bye. Bye everyone.
Bye.
Yeah. Bye.
Wow.
Bye. Good day.